say, you don't even need to do below the level of my injury because I can't feel it, I don't use it, so just concentrate on my upper body. But again, that's going to be patient specific, and they will generally tell you what they want. What else can I tell you? Spastic muscles tone. It is not unusual if you are working on an affected area that is tonic, that when you get to dig in there that you will induce a spasm. As long as it's not painful for the person or causing them pain or causing them to go into a position that is compromising a joint, I'm going to say that it's okay. Because generally, when something is tight, when they have a trigger point, it's going to cause more abnormal hypertonicity that we then in therapy have to fight through or overcome in order to get the opposite muscle working. And so what we do a lot of times when we're doing soft tissue work is we're pressing on those trigger points, we're pressing on those areas that are causing a spasm until they stop causing the spasm. And then that lets go, and now we can train the opposing muscle group, strengthen the opposing muscle group, and that helps to bring the overall level of tone down. So don't be afraid about inducing a spasm, and most folks will tell you if they have, it's another good question to ask, do you have painful spasms, and if so, what causes them? But if their spasms aren't painful, it's not necessarily a bad thing. If your intention is to work out these knots, work out these trigger points, it's not a bad thing that you're causing the spasm. A lot of people will have a spasm when they change position. So they're sitting up and they're in a lot of flexion, and then you lay them down and everything straightens out and everything will just spasm and then it'll relax. Again, it's not something to be afraid of. It's very common, and something that you can ask beforehand, is this change of position going to induce a spasm, just so that you're ready for it? Are they painful? Is there anything that I can do to minimize it? And usually people will just say, it's going to happen, doesn't bother me, it'll be over in a couple seconds, don't worry about it. What else?
I do have a question.
Yes.
I dated a gentleman who was a quadriplegic, and he was having autonomic dysreflexia.
Okay, great term, and that's actually, I'm glad you brought that up. That's very important for everyone to know. When you have and Bryn would kill me because she will know the exact level. When you have a lesion above, somewhere in the thoracic, yeah, so people who have a lesion in their cervical region, in their upper thoracic region, are prone to something called autonomic dysreflexia. Autonomic dysreflexia is a medical emergency because what happens is some sort of noxious stimuli causes the sympathetic nervous system to go into overdrive, and it sends their blood pressure very high, or it can. What they will complain to you of is usually a pounding headache. Some people have unusual symptoms for autonomic dysreflexia, and they know what their symptoms are. Headache is usually one of them, a red face, sweating above the level of their lesion. Basically, anything that is an acute change when you're working with a person should get your attention. So you're working and they're not sweating, and then all of a sudden they break out into a sweat. That should get your attention. And this is going to be more with your people who have spinal cord injury. You notice all of a sudden an acute color change in part of their body. That, obviously when you're working, you expect changes in blood flow, and you're going to have some redness on the areas that you're working. But like if their whole upper body turns red, there is a problem. Now, it doesn't mean that you have to call 911, but you do need to stop what you're doing and address the issue. Usually your culprits are something is tight and bound up around them. So check the sheets, make sure nothing is, binding anywhere, tight, tucked in. The other thing is, and if they're still wearing clothes, you want to just kind of check and make sure that their clothes haven't gotten bound up as they're moving around. People who have catheters, another common cause of autonomic dysreflexia is that catheter has gotten kinked somewhere. And so that would be another thing that you or you would need to, suggest to them, hey, can we check this? Those are going to be the things that are acute, or something in your pressure is too stressful for their system. Other causes of autonomic dysreflexia could be things like a urinary tract infection or an upper respiratory tract infection, pressure sores, but they're going to know that before they get onto your table, that they're dealing with that issue. But definitely in someone with a spinal cord injury, an acute change, you should stop, figure out why the change. Now, if you figure out the cause and they come back down to their normal baseline, there's no problem with continuing. You don't have to end the session at that point. But if you can't figure out the cause and their symptoms are not improving rapidly, it is a case where if their blood pressure goes higher and higher and higher, they could stroke, they could, it could be a very bad scenario. So if things are going south and you cannot figure out, that is a time to call 911. And we've had to call 911 for someone with autonomic dysreflexia at our clinic before. So it is definitely worth paying attention to. But again, this is not going to be for your people who've had a stroke. This is not going to be for your lower, like lumbar area paraplegics. This is going to be people who have lesions that are much higher up, and so they're going to tend to have a lot more weakness. They're going to need a lot more help getting on and off the table. I would say it would be fairly unusual for someone like that to come in here, but I don't know. I mean, I know that you did a lot of body work with him, but you did it at home, right?
No, he was actually quite mobile. It was an incomplete C5, C6 incomplete. So he was able to live by himself and take care of himself pretty much. He just couldn't drive.
Okay.
So he was really high functioning.
I did refer somebody over here that was ambulatory, that was an incomplete cervical, but he had never had autonomic dysreflexia, so I guess that's why it didn't occur to me to think about it. Autonomic dysreflexia, though, is one of those things that when a person is injured, it gets drilled into their head over and over and over again what it is, what causes it, and what to do about it, because it is one of those things that is unique to spinal cord injury, and it's very common that even medical professionals don't know what it is or what should be done about it. So you could have someone with a spinal cord injury with this ridiculously high blood pressure, and they go to the ER, and the people in the ER are not familiar even with the term autonomic dysreflexia. And so there is a lot of education that goes into teaching people who have spinal cord injury that this is a thing, and that they need to be aware of this thing, and they need to, be able to explain either with a card that they carry with them that explains it, or that they verbally explain to providers what it is. So, I don't know if on part of your medical history form, if it comes up that someone has a spinal cord injury, if there's a question on there that says, do you suffer from autonomic dysreflexia, or what triggers your autonomic dysreflexia? And again, it's probably not necessary to have it on your everyday form, but if you are starting to see more and more people who have spinal cord injuries, it might be worth it to have a little supplementary thing that people fill out to ask, what sort of assistance do you need for transitioning on and off the table or positioning on the table? Do you have autonomic dysreflexia, and what triggers it? Are there certain positions or things that trigger spasms? Do you have painful spasms? So you could have like a little neurologic supplement, which I would be more than happy to work with you to figure out some appropriate wording and questions and things to ask to have on that supplement if you are seeing more and more of those clients. Yeah, that would be great. And then we try, when we refer people over here, if we know that they have unique needs, we do try to, at least on the initial time, communicate with the therapist so that okay, Kurt understands everything that you're saying to him, but he's not going to be able to tell you very much. Or here are some strategies of how you can understand what he's trying to communicate with you. Because we definitely do have a fair number of folks that come in that have aphasia, and so they're not able to really articulate what they want, what they need, but there are ways to enhance communication. And so when we have clients like that, we do try to give you all a heads up about why they might be coming over here in case they can't tell you themselves, and if there are some issues. But if you ever did have one of our clients, I know 99% of the patients that come through our door personally. And so if it is a neuro client and you have a question, please come over. Don't be afraid to interrupt me. You know, just say, hey, so-and-so is here. Can you give me just a little heads up or something? And I'm more than happy to do that. Also, if you ever get a client in here that is, even if they're not one of our patients, but you're having trouble getting them on the table, or especially if you're having trouble getting them off the table, and you need some help with a transfer, please don't hesitate to come over and ask. Can't do you much good if this is like your 8 p.m. patient and we're not there, but you know, any other time, we're always willing to come over and lend a hand if you need it. So please don't hesitate to pop over.
Is that something, just out of curiosity, that you guys like are trained in, is helping people like this up off the table, or no, you don't?
We just got the training.
Yeah.
Okay, that's what I wondered.
Yeah.
I didn't know if that was
I would
part of
say
your
that
role,
that
or
was a
part
little
of-
gap we needed to fill.
Yeah.
Okay.
I did from working in the PT office.
Yeah.
Most of it.
Well,
Yeah.
that's, I know a
But
couple
at
of
the
you guys
basic
know
massage
how to
level,
do that.
no.
Yeah, okay.
Be nice if they did.
Yeah. And
I don't know if they'd be ready for it.
you know, as I am also more than happy to come back, you know, as specific questions come up, if you say, you know, I ran into this situation, I really didn't know what to do, I'm happy to work with you all any of our therapists are happy to work with you one-on-one outside of that session or even with a particular client. It generally helps if we have a little bit of notice so that we can either get another therapist to cover our client or whatever, but you know, just let us know and we'll do our best to pop over and help anytime.
Cool. Thank you.
All right.
And just as an FYI, a couple things popped in my head for you all. If someone cannot get out of the wheelchair, we lock the wheelchair, we can still give the massage. If someone wants to learn how to work with their partner to give massage at home, we're a teaching practice. We're happy to help out.
Now, see, that's a really good point because we do have a lot of people who are really tight and they really would benefit from every day or every other day somebody working as part of the stretching program and in addition
Yes.
getting in there. And
Wouldn't
so
that be
that's
nice
a
to?
really nice,
It's a wonderful bonding thing, especially if somebody's still working through emotions around the injuries as well. So we're here for you.
well, that's a really
Yum.
good idea, and let's
You and
talk
them.
some more about how we might kind of
We could even pull together a
Class
special
or-
populations class, just
Yeah.
like you guys did with the Tai Chi.
yeah.
I am slowly learning aromatherapy, which could also
Mhm.
possibly help in the future.
Yeah, and I'm sort of teetering on my interest level in like the essential oil. I have so many colleagues that are doing it, and I haven't kind of bridged that gap. But I'm thinking about incorporating that into my practice as sort of my next level of learning from the aroma side of things, but also things that are direct contact with the skin and that kind of stuff. So
Pretty awesome stuff.
yeah.
Well, thank you so much.